Well, good afternoon, all. Thank you for joining us for our spinal cord injury lecture series. I'm actually starting things over again with fresh new start. So we'll be discussing acute management of spinal cord injury, and hopefully this will bring some additional opportunities for discussion as we move forward. So I want to talk through the epidemiology of spinal cord injury and then discuss some of the acute interventional strategies that we have, including neuroprotection and decompression, review functional outcomes associated with spinal cord injury, and we'll be discussing mechanisms of spinal cord injury and spine stability, including use of orthotics for additional stabilization and support after surgeries. So we know that the incidence of spinal cord injury, at least traumatic spinal cord injury, is about 54 per million in the population, recognizing that about 77% of those individuals survive, so that we have almost 18,000 new spinal cord injuries in the United States each year. And again, these are traumatic injuries and don't include all of the non-traumatic spinal cord injuries that we see as a result of vascular dysfunction, infections, tumors, and those types of things. It's reported that we have a prevalence of somewhere between 250 and 373,000 individuals in the United States with spinal cord injury, at least based on the National Spinal Cord Injury Model Systems Statistical Center. We see approximately 4 times as many men as women, and the race before 2015, about 60% of individuals with spinal cord injury were white or Caucasian, about 14% Black, and about 1% Asian. Since 2015, we now see about 58% non-Hispanic whites, 24% non-Hispanic Blacks, 13.3% Hispanics, and about 2.5% persons with spinal cord injury are Asian. Now, the Christopher Reeve Foundation has put forward numbers that are a little bit different. And again, these numbers include not just traumatic, but also non-traumatic spinal cord injury. They feel the incidence is approximately what is reported with the National Statistical Center, but feel that there is more likely a prevalence somewhere around 1.25 million. So they also report gender about 3 times as many men as women. And again, the race demographics reported out by the Christopher Reeve Foundation is approximately 77% white or Caucasian, 16% African American, and 7% Native American. So the time since injury, or the time at injury, the age at the time of injury in the 70s was 29, almost 30 years old. We've got kind of a bimodal distribution now in terms of people who are being injured, some very, very young in the 16 to 25 age group, but some over the age of 65. So the mean age since 2015 is about 43 years old at the time of injury. And you see the distribution as it's reported out with the National Statistical Center. Again, the Christopher Reeve Foundation has reported out current age. This is not age at the time of injury. And so the pie looks a little bit different in that we're seeing approximately 30% of folks with spinal cord injury are between the ages of 40 and 49, about 25% between the ages of 50 and 59, and then it kind of breaks down those between the ages of 60, 69, or those between the ages of 30 and 39. So again, the data looks a little bit different, but this is their current age and not the age at the time of injury. We look at, again, traumatic spinal cord injury. The cause since 2015, the leading cause has been vehicular collisions, followed by falls, and then violent acts. So we see approximately a third related to motor vehicle collisions, approximately a third related to falls, and then it kind of breaks down after that. The remaining third of the pie is sports, medical, surgical issues, and then other issues. So again, as we look at the Christopher Reeve Association data, or the Christopher Reeve foundational data, we see almost quartered industrial and motor vehicle collisions. Recognize that in this presentation, the industrial spinal cord injuries that occurred could include those who were driving a vehicle at the time while they were working. So, and then it breaks down to sports and recreation, again, falls and violent acts as we go through this. So I'm going to be jumping through this fairly quickly. Demographics for some folks, very exciting. Some of us maybe not so much. And so approximately 50% of new traumatic spinal cord injuries are incomplete tetraplegia, followed by fairly similar proportions of incomplete paraplegia and complete paraplegia. The complete tetraplegia falls out to about 12%. And again, these are numbers since 2015. Lifetime costs for spinal cord injury. And again, this is based on information that just came out this year. Those with high tetraplegia injured at the age of 25 will spend approximately $5.2 million during the course of their lifetime. If injured at 50, high tetraplegia would still require approximately $2.8 million, just in terms of the lifetime costs. For paraplegia, about half the amount spent for high tetraplegia, whether at the age of 25 or at the age of 50. Life expectancy for those who survive the first 24 hours breaks down like this. So if the age at time of injury is 20, then those with paraplegia, somewhere around 44.8 years. On the other hand, if individuals have survived at least 1 year post-injury, then we can see those numbers improve a little bit as we look along, recognizing that those with ventilator dependency are still going to have a shorter expected lifespan than folks with lower levels of injury. So injury to the cord, remember that only about 10% of the spinal cord are actually nerve cells. About 90% is made up of glial cells. And when we look at the neural tracts and the way that they run through the cords, there is a very tight relationship between how those fibers lie, whether they're cervical, thoracic, lumbosacral, and position vibration, or if they're cortical spinal tracts, that is those tracts that run from the brain back down to the body. We see that there is a similar relationship, again, sacral fibers mostly on the periphery, and cervical fibers in particular more centrally located. So again, this very simplistic cartoon, but we recognize that the cord has descending tracts that send nerve impulses to the rest of the body, as well as afferent impulses that ascend from the body up to the brain. We have at about 1 centimeter intervals, sensory fibers coming into the cord. Those are afferent fibers, and efferent fibers going out, sending out motor information. We have interneurons, some of which can be facilitatory and some of which can be inhibitory. And so again, this very simplistic cartoon just helps you to understand the devastating injury of something to the cord. So if we look at just repairing it, let's just fix it. There are a number of things that we would have to fix in order to have full conduction of nerve impulses through the cord. So first off, there is a significant glial scar that occurs soon after the spinal cord injury and persists for some time. You'd have to break through that glial scar with new neurons to allow communication fore and after the injury. We recognize that there's typically a cavity. We could put cells in there or a scaffolding sort of a bridge to allow new nerve cells to, again, grow upwards or downwards from the site of injury. But there are also a number of inhibitory proteins that we would have to overcome. The no-go proteins, myelin-associated glycoproteins, tumor necrosis factor alpha, nuclear factor kappa B. All of these are inhibitory proteins that are actually hostile to new neural cell development. But if we could somehow disinhibit those inhibitory proteins, we would still need growth factors present at specific times and in specific concentrations during the nerve cell's development. If we could get all of those things fixed, we would still have to figure out how to provide directional guidance to these new neurons so that they would appropriately communicate only with the nerve tracts that they're supposed to. Otherwise, we're going to have significant misfirings, neuropathic pain, and spasticity. So when we look at the central nervous system, we recognize that it is a mix of somatic and autonomic nervous systems. The somatic nervous system I'm going to be spending most of my time talking about today, again, provides us specific levels of injury, provides certain myotomes or motor function. But we also have to keep in mind the autonomic nervous system, and particularly the sympathetic nervous system that arises from the thoracolumbar regions of the cord. So the somatic nervous system disruption, we're going to be going over this in a few weeks and talk about completion of the International Standards for Neurological Classification of Spinal Cord Injury, where we will indicate the myotomes, we will indicate the dermatomes for light touch as well as for pinprick, and give us a neurological level of injury so that when we communicate with each other, we're all speaking the same language. In addition to the somatic nervous system, we do have the autonomic nervous system, and again, sympathetic nervous system arises from thoracolumbar regions of the cord. Parasympathetic nervous system arises from cranial sacral axis. And following a high spinal cord injury, there is a significant parasympathetic dominance. So remember, the sympathetic nervous system conveys fight or flight, ergotropic responses, so that we can get through a crisis situation. The parasympathetic nervous system, on the other hand, arises from the cranial sacral neuraxis, and that provides rest and digest types of functions. So energy conservation to replenish any substrates that have been utilized during the crisis situation. So I want to talk through, again, the acute emergency management of spinal cord injury. Obviously, things that we want to start with include the primary survey for airway, breathing, and circulation, protecting the airway while stabilizing the spine. And this device has been around for a couple of decades now, the Kendrick extrication device. You can actually put this in behind a person in their car seat without moving them, without destabilizing the spine, so to speak, and then keep the spine well aligned as you extricate them from a vehicle. Other things that we're going to be looking for during that initial assessment: do they have paralysis and sensory loss? Do they have pain, lacerations or bruises, perhaps at the fracture site? Are they paradoxically breathing, meaning that as they take a deep breath, instead of elevating the rib cage, it appears that their abdomen is being distended, and that's because the diaphragm is pushing down against the abdominal contents without the benefit of abdominal muscles holding so that you can take a deep breath. So almost immediately after a spinal cord injury, folks are going to have difficulty with their tidal volumes. Bowel bladder continence are going to be issues, and then managing neurogenic shock as opposed to hypovolemic shock. And we'll talk through that in a little bit more detail. So the transport, if the person is within 50 miles and it's not heavy traffic congestion, then an ambulance is appropriate. Oftentimes, particularly Florida, as we look at our major highways, and particularly I-95, we would want to probably use a helicopter, and or in those areas where you have large distances to traverse. So for example, up in the northwestern United States, up in Canada, et cetera, consider it fixed wing aircraft. So as you bring folks in, the folks in the trauma bays, the emergency departments are preparing and assembling the team. That is going to include the emergency physician and trauma surgeons, neurosurgeon and or orthopedists to take care of the spine, physiatrists, anesthesiologists, and respiratory personnel, again, because oftentimes these folks are going to be having difficulty with their breathing because of neurogenic restrictive as well as obstructive lung disease. So typically we think about hypovolemic shock. The person has lost blood, and so their blood pressure drops. In response to that, they develop a tachycardia, a compensatory mechanism to try to maintain perfusion to vital organs. After spinal cord injury, there's also neurogenic shock that we have to consider. So yes, the blood pressure is low, and they will again be hypothermic, but they can't compensate. The sympathetic nervous system is essentially blunted, and so they may develop neurogenic bradycardia in the early hours following a spinal cord injury. Some will require temporary cardiac pacing. The ER ventilatory assessment, very important, and particularly for those that we demonstrate a vital capacity less than a liter, they are going to require immediate intubation and mechanical ventilation. Close monitoring for those with vital capacities between 1 and 1.5 liters. Usually folks who have vital capacity greater than 1.5 liters are going to be stable, but we're still going to be checking in on them frequently. Recognize that most of these folks are going to have problems with secretions because of the parasympathetic dominance causes bronchoconstriction and mucus secretion. So we'll be putting in nasogastric tube to prevent emesis and aspiration, and then just recognizing the folks are going to have bladder incontinence and or bladder paralysis. So making sure that we have a catheter, indwelling catheter, to help prevent urinary tract infections, incontinence, and spasming. Usually that wouldn't occur until later in the spinal cord injury course. So ideally, we would have acute decompression of the spinal cord injured area. It appears that there's improved recovery. We'll be doing a separate lecture just on prognosis, so I'm not going to spend too much time on this at the moment. Recognize that there may be fewer mortalities if we wait, but we also probably lose that window of time to do the decompression and to preserve as much sensory and motor function as possible. Following a chronic spinal cord injury, we may have tethering of some elements of the cord, and that may also cause some problems with loss of function over time. So neuroprotection, this was a big focus in the 80s and early 90s, trying to reduce secondary swelling and to reduce the inflammatory cascade, hopefully to diminish the injury, activate the cleanup process within the cord itself, and reduce the immunological attack of transplanted cells and tissues down the road. The bottom line is, when we look at all of this data and the North American Spinal Cord Injury Series 1, 2, and 3, we thought that methylprednisolone was buying some improved motor outcomes. But as the studies have matured and we've looked back at additional data, we've somewhere around the turn of the century, actually it was 2002, there was guidelines put together for the management of acute cervical spine injuries. And after looking through all of the data, they did say that methylprednisolone could be recommended as an option, but it wasn't felt. In fact, in some cases, it was thought that there would be more harmful side effects because of using these high-dose glucocorticoids than would be suggestive of clinical benefit. So GM1 also recommended as an option, but again, insufficient evidence to support treatment standards or guidelines. So consider methylprednisolone early on in the course. Generally, this is frowned upon now. And we also know that the early data didn't include individuals under the age of 13 or those with gunshot wounds, for example. We would like to have an assessment done using the American Spinal Injury Association impairment scale, where we're documenting, again, motor sensory function and sacral involvement. The initial spine assessment is going to include radiographs, and yet probably more importantly, computed tomography, so CT scans looking at the bony stability, and MRI looking at soft tissue damage that occurs. So in terms of functional classification, again, we're going to be going through this in a few weeks. Initially, we reported things out by the Frankel classification that was put forward in 1969, basically addressing the completeness of an injury, the level of the injury, as well as the completeness of injury. Briefly, I'm going to talk through the old Frankel classification, basically indicating there's no motor or sensory function spared below the level of the injury. For a complete injury. For incomplete injuries, you had sensory but no motor function spared below the level of the injury. That would be a Frankel B. Frankel C is if you had less than 3 out of 5 motor strength in the majority of muscle groups below the level of the injury. That would be a Frankel C. Frankel D, more than anti-gravity strength in the majority of muscle groups below the level of the injury. And then Frankel E, you had essentially normal motor and sensory function below the level of the injury. Why would you report that? Because you'd still be at high risk for spasticity, and particularly detrusor sphincter dysinergia, and ongoing problems, even though motor and sensory function appeared normal. Now, in 1992, the International Standards for the Neurological Classification of Spinal Cord Injury was put forward in and included the American Spinal Injury Association scoring of particularly sacral function. And so literally folks just became that much more anal in determining, because as we talked about before, the potential sparing of sacral elements could portend for a better prognosis. And so essentially you still have, instead of Frankel now we're going to call it the Asia Impairment Scale A, is a complete injury in which you have no motor or sensory function spared, particularly no sacral sparing. Incomplete injuries include Asia Impairment Scale B, where you have sensory spared and sacral sparing. Asia Impairment Scale C is, again, less than anti-gravity strength in the majority of muscles below the level of the injury and sacral sparing. Asia Impairment Scale D is more than anti-gravity strength in the majority of muscle groups below the level of the injury and sacral sparing. And then Asia Impairment Scale E, 5 out of 5 motor and sensory intact, including sacral function. I'll talk through briefly the clinical syndromes of incomplete spinal cord injury. So again, we're going to be spending much more time on this in the next couple of weeks. So let me just move forward. At this point, we do want to identify as soon as possible, ideally within 72 hours, the person's initial level of injury and completeness of injury, because that helps provide prognosis. But we also, in outpatient evaluations, want to follow up each time and ideally report out any changes in motor or sensory function spared, especially during annual evaluations, because you don't want to lose additional motor function. And any changes could essentially be a neurosurgical emergency. So running through the dermatomes, there's a nice picture of what they look like. I wanted to talk through central cord syndrome. So again, typically a hyperextension injury with older individuals who have spinal narrowing because of degenerative changes in the neck. We know that the swelling affects central more than the peripheral cord, but the upper extremity weakness that we see associated with this, probably not just somatotopic anatomy. In other words, you know, the cervical fibers more centrally located than the thoracic fibers. But what we do know is that you're going to see upper more than lower extremity involvement, probably due to white matter axonal disruption in these areas, particularly in the cortical spinal tracts. So again, upper extremity more than lower extremity weakness is kind of the hallmark for the central cord syndrome. The Brown-Séquard syndrome is when you've had a hemisection or hemi-injury to the cord, so just one side has been involved. So typically associated with that, you're going to have ipsilateral loss of motor and position vibration sensation, contralateral loss of pain temperature. And again, this is just a matter of recognizing what levels the afferent sensory information ascend and cross over, as well as the cortical function. So moving forward, anterior cord syndrome, typically associated with repair of an abdominal aortic aneurysm. Remember that you have at the level of somewhere around T10 to L2, the great artery of Adamkiewicz. So as we save the person's life in repairing these abdominal aortic aneurysms, if you clamp above the level of that artery, the great artery of Adamkiewicz, the person is going to wake up having damage to the anterior 2/3 of the cord. So they will have sparing of position and vibration, but they will still be missing pain, temperature, and motor function below that level. Conus medullaris syndrome, again, typically associated with a burst fracture in the lower thoracic or upper lumbar vertebral column. Recognize this involves both the spinal cord as well as portions of the cauda equina as these peripheral nerves are coming off. So typically you're going to have a lower motor neuron, bowel, and bladder and saddle anesthesia that would go along with this level of injury. Cauda equina syndrome is involvement just of the peripheral nerves, the cauda equina. Essentially sparing of the cord itself. But in this circumstance, because these are peripheral nerves, the person will have an areflexic bowel and bladder and typically a flaccid paralysis as opposed to a spastic paralysis that we typically see with a spinal cord injury. Unfortunately, often associated with severe neuropathic pain because of damage to those peripheral elements. So I'm going to run through this relatively quickly, but just to give you some idea, we're going to be doing this in much more detail in a couple of weeks as we go through the INSCI examination. But essentially, we don't have a dermatome or myotome for C1, but C2, basically dermatome is about a centimeter behind the person's ear. Most of these folks are going to be requiring mechanical ventilation and or assisted ventilation, for example, with a, in this case, phrenic nerve diaphragmatic pacemaker. C3 is, we still just have the dermatome is in the supraclavicular fossa, but no motor associated with that, at least on the ASIA examination, recognizing that C3 does contribute to phrenic nerves, and a person with C3 tetraplegia in some cases can be weaned off of a ventilator because they have a third of the phrenic nerve still intact bilaterally. However, most folks wouldn't be able to be weaned off a ventilator with a C2 or a C3 level of injury. C4, so the sensory dermatome is out just over the AC joint. We have C3, C4 contributing to the phrenic nerve. So at least 2/3 of the phrenic nerve bilaterally would be intact. And most of these folks, the majority of these folks would be able to be weaned off a ventilator, but they're still going to have neurogenic restrictive and obstructive lung disease. So functionally, they can inhale, shrug their shoulders, and turn their head from side to side, but not much below that. And again, I'm assuming a motor complete injury as we go through these. C5, the dermatome is at essentially the lateral epicondyle. These folks will have motor function of the shoulder muscles as well as the elbow flexors, the key muscles, according to the INSCI examination, the elbow flexors. Functionally, they could flex their elbow. That means they could feed themselves with a cuff, for example, and a spoon and or fork. They can abduct internally and externally rotate their upper arm. C6 tetraplegia. Now, if we look at the dermatome, the one spot is, I would look at the dorsal surface of the thumb. The motor function would be the extensor carpi radialis, longus and brevis. And so typically, if a person has a C6 complete, motor complete spinal cord injury, as they extend their wrist, it puts their finger flexors on stretch. They'll have a little bit of a radial deviation because, again, this is extensor carpi radialis. Some of these folks would be able to use tenodesis, that is, the passive flexing of the fingers with wrist extension, because you put the finger flexors on stretch as you extend the wrist. So folks could potentially cath themselves with this level of injury, particularly if they were to use an amplifying splint, so a tenodesis splint. C7 tetraplegia, the dermatome is at the middle finger. Again, the dorsal surface is what we look at. Motor function includes the triceps, so elbow extensors primarily, but also includes the wrist flexors and extensor digitorum communis. So these folks would be able to extend their elbow, flex their wrist, and extend their fingers. C8 tetraplegia, sensation would now be at the little finger. It would still need to be intact if we say somebody has C8 tetraplegia. The motor function is to the flexor digitorum profundus and the flexor pollicis longus. So these folks can grasp and hold, flex their fingers, flex their thumb, and have a grip. As we look at thoracic paraplegia, working our way down, T1, so medial epicondyle essentially, is the primary dermatome. We don't list the actual myotomes as we come down. We assign the myotomes according to the dermatomes as we come through there. So T2, the dermatome there is in the axilla, T4 at the nipple, T6 the xiphoid process, T10 at the umbilicus, and T12 the inguinal ligament just above that. The further down the injury is, the more function the individual will have with regards to paraspinal function, with regard to activating the intercostal muscles and the abdominal muscles. So they're going to have more truncal stability and be able to exhale if they have all of their abdominal muscles intact. If their level of injury is, say, above T8, they are generally going to have a neurogenic restrictive lung disease and probably not be able to generate a significant cough. So the L1 dermatome runs just below the T12 dermatome, so below the inguinal ligament. And then L2 basically is anterior medial thigh, midway between the inguinal ligament and the medial femoral condyle. Motor function is the iliac psoas, so these folks can flex their hips. As we look at L3 paraplegia, again, sensation is going to be just crossing the VMO complex at the knee, so the medial portion of the knee. The key muscle group or myotome is the quadriceps, and so these folks would be able to extend the knee. Generally speaking, using ankle-foot orthoses, these folks would be able to ambulate and be community ambulators, assuming that they have a fairly strong quadriceps. At least one leg is required. L4 paraplegia, so these folks have sensation present at the medial malleolus, and the motor function is the tibialis anterior, so dorsiflexion. These folks, generally speaking, are going to be able to clear their toes okay. However, if they're just barely anti-gravity, they may still require an ankle-foot orthosis for community ambulation. L5 paraplegia, so now we look at the third ray, so metatarsal in the mid fourth foot, these folks are going to be able to extend the great toe. They'll also proximally be able to activate the gluteus medius. And so being able to have some hip abduction. So if we look at S1 paraplegia, I didn't put my marker in the right place. So sorry, we look at the lateral heel. That's the S1 dermatome. The myotome is for the gastroc complex distally, the gluteus maximus proximally. Recognized for the INSCI classifications, we only look at the plantar flexors as the key muscle group. S2 dermatome is in the popliteal fossa, S3 is over the ischial tuberosity, and then S4 and 5 into the anal sphincter. So again, most folks who have this level of paraplegia will have bowel incontinence, bladder incontinence, and essentially flaccid sphincters. So more on that as we continue through. Okay, I'm trying to move forward. There we go. So again, outpatient clinic is important for us to keep track of any changes in sensation or motor function as we follow up with these folks. There are outcomes provided by the consortium of spinal cord injury physicians put together by the PVA group. And essentially we have expected outcomes at each level of spinal cord injury. And yet these guidelines really only hold true for about the first 5 years, recognize that with aging and degenerative changes, et cetera, we may have limitations in their true functional outcomes as the individual ages. So I'm going to go very quickly through the spine assessment. This is not just cord now. And the reason I do that primarily is because I'm trying to demonstrate to you a stable versus an unstable spine. So basically the 3-column spine put together by Dennis still holds true. And I know that there are some who feel like it's a bit outdated. We'll talk about Vaccaro's instrument in just a few minutes. But essentially, if you have 3 columns, the anterior column being essentially the anterior vertebrae, the anterior disc, and the anterior longitudinal ligament. The middle column basically is the posterior vertebral body, posterior disc, and the posterior longitudinal ligament. Posterior longitudinal ligament is key, and I'll just put that out there because if it's disrupted, regardless of the other findings, you're going to have an unstable spine. So we'll come back to that in a moment. And then the posterior column basically includes the vertebral arch, the ligamentum flavum, so between these, and then you have the spinous process, so the intraspinous ligament and the supraspinous ligament as we look through those. So surgical stabilization recommended if you have more than 2 columns involved. Again, mechanisms of spinal cord injuries can give us a good indication of whether or not there would have been spinal cord disruption. So if we look just at cervical spine injuries, for example, the neck is essentially mechanically unstable. It allows us to do a lot. We can turn our heads, et cetera, but it's going to be very vulnerable to trauma. So about 40% of cervical injuries will have neurological deficits. Most are lower cervical regions just because of the lordotic curve typically associated with that portion. And then rarely do we see C1 and C2 injuries, partly because of the large canal size, but also death at the time of impact. Remember, that's going to cut off your breathing. So I'm going to run through different mechanisms for cervical spine injuries, recognizing that these same mechanisms essentially will hold true for the thoracic and lumbar spine as well. So if you look at compressive flexion, this typically is going to be associated with a high incidence of neurological deficit because you will have disruption of the anterior as well as the posterior components of the cord. And most commonly, this is rapid deceleration, head-on collisions type of a scenario with significant neurological deficit. Distractive flexion is essentially the same mechanism, but the person has rotated their head at the time of injury, so that you end up with total disruption of the intervertebral ligaments, freely mobile vertebrae, and typically bilateral lock facets. And so having these folks in traction as they try to decompress the cord is going to be very, very important. But typically you're going to have more than 50% displacement, one vertebral body over the other as it goes through there. Vertical compression, so axial loading through a straight or slightly flexed neck. So for example, diving in and hitting your head on the bottom, or standing up quickly and hitting your head on, say, an overhead bin, for example, on an airplane, can drive bony fragments posteriorly into the canal and have significant deficits. So compressive extension, so now you have essentially anterior distraction, posterior compression. Typically, we think of the Netter diagram where the person falls in the bathroom and hits their chin on the toilet seat. We also see this in rear end collisions. So essentially, you're going to have significant disruption of the anterior longitudinal ligament, and again, compression of the posterior elements of the vertebrae. Distractive extension, so now you have the added rotation in there. And so this is the type of scenario, again, where you end up with bilateral lock facets and severe neurological deficits. Lateral flexion, somewhat rare, but occurs, for example, a motorcyclist who hits the guardrail as they come off. Typically, this type of a cervical injury is also going to be associated with a brachial plexopathy, most likely upper trunk, but it depends again on exactly how the person hit. Essentially, the mechanism of thoracic injuries, very similar to what we just talked about. These are more likely to be complete injuries because of the extreme force required. Why extreme? Because typically you've got the whole rib cage there protecting the vertebrae as well. So if you do have significant enough force to cause disruption, one vertebrae over the other, you're more likely to have a complete injury. There's also a relative watershed zone in the regions of the thoracic cord. Your vascular supply is not as robust, and you have a relatively small canal size, the vertebral canal. Most commonly, you're going to see this T12 to L1 junction meeting, one of the areas where you're going to be particularly at high risk for damage. So again, I'm not going to beat these to death. Compressive flexion. We also may have distractive flexion. And again, when you have this element of rotation in there, more typically severe neurological deficits. This almost always includes a 3-column involvement, again, with bony fragments in the canal. Vertical compression, so struck by a falling object or landing on essentially the upper thoracic spine, buttocks, or feet. You have this crushed vertebral body, and again, fractured arch and bone being pressed into the spinal canal. Lumbar injuries, the mechanisms, just like we talked about before, neurological damage is usually incomplete as we get down to the lumbar, because you have a larger canal and a pretty good vascular supply in most cases. You also have the cauda equina coming down off of there. So generally speaking, we worry about a distractive flexion. So this is, for example, before we had the shoulder belts and we only had the lap belts, seat belts, folks would fold themselves over this, and essentially that fulcrum would cause damage, including abdominal injuries associated with this. So what about surgical stabilization? Again, about 45% of individuals will not require surgical stabilization, but about 50% will require 1 spine surgery, and 5% will require 2 spine surgeries, often anterior and posterior, as we go through that. So the goals of surgical stabilization are to restore the spine alignment, to establish stability, to prevent further neurological damage, and to hopefully improve neurological recovery. So again, Vaquero put out in 2005 the TLIX, so this is thoracolumbar injury classification and severity score. And the bottom line is we worry particularly if you have damage to the posterior ligamentous complex. You add up points based on a complete burst fracture, for example, incomplete versus complete neurological disruption. And essentially, as you look through this, these points, if you have more than 4 points, and I'll go back to that again. If you have more than 4 points, then it's pretty sure that you should stabilize the spine, and otherwise it will be unstable and likely to result in significant problems in the future. So again, the posterior ligamentous complex, when disrupted, typically you're going to want to be doing an anterior and posterior approach to stabilize the spine. I'm not going to go into this in much more detail. I just wanted to talk briefly about post-op management that is essentially spine precautions. So essentially, we want these folks to log roll only, maintaining a neutral spine. Typically, if they're going to be out of bed, we're going to have them in the orthosis, recognizing that the spinal orthosis is only as effective as its fit. So these are typical post-surgical restrictions. I want to briefly just talk about the orthosis. We don't see the halo much anymore. It works very well, restricting about 90% of flexion and extension, as well as rotation and lateral flexion. Requires a well-molded vest. Over the back in the day when we had folks longer in the acute rehabilitation phase, I would typically see that we would have to modify this vest over a period of weeks that the person was there, because they will have lost significant weight, muscle mass in particular at the chest and the back. Great orthotic, we're seeing it less and less because folks are doing, I think, stronger stabilization surgeries. We really don't see the sternal-occipital mandibular immobilizer, the SOMI, much anymore. It used to be always causing pressure injuries at the chin and then at the back of the head. So generally not using this as much. The majority of our folks that come to us after neck surgery are going to be in a hard cervical collar. When fit appropriately, restricts about 75% of flexion, extension, and lateral flexion, but it doesn't limit rotation very well, only about 50% when it is fit properly. Most folks try to loosen it up and squeeze their chin down within it, and then they have essentially full range of motion, and that's not what we're trying to do. We're wanting to restrict their motion during this healing time. Soft cervical collar, generally not used, not useful. It's a reminder that, yeah, you did something to your neck, but generally speaking, as I wean somebody out of a cervical collar, I don't take them to from a hard to a soft collar as we go through there. The TLSO, basically the fit is like a clamshell. So if you incorporate the hips, so as I have in parentheses here, you can restrict 90% of flexion and extension. It'll also restrict 70% of flexion extension if you incorporate the hips, and then 90% of rotation if you incorporate the hips. The problem with incorporating the hips, then you take away our therapist's ability to teach higher mobility tasks. And so essentially we have to wait until the orthosis comes off at approximately 12 weeks before we can go to those more complex mobility tasks. So an LSO, again, just a lower level, maintaining essentially precautions of the lumbar spine as we go through there. And then my next talk is going to be about the comorbidities associated with spinal cord injury. Recognize that those folks with a high cervical injury basically are going to have all of these, and we'll spend the next 20 weeks or so going through each one of these about an hour at a time. So open for questions, thoughts, concerns. Please feel free to check and see if there was anything in the chat. Nobody put anything in the chat yet. Are there questions out there? Hearing none. Again, I will go ahead and close this down. I appreciate those of you who participated. If you do have questions, feel free to reach out. Also, if you'd like to get a copy of these slides, I can provide the PDF versions. Unfortunately, the PowerPoint versions are too large in size for me to send electronically to you. So everybody have a great week, and try to, as much as possible, prevent spinal cord injuries. Think first. Everybody have a great day.